Welcome friends. Today we will discuss about atrial fibrillation. Atrial fibrillation is the most common sustained cardiac arrhythmia with an overall prevalence of 0.5% in the adult population of the UK. The prevalence rises with age, affecting 1% of those aged 60 to 64 years, increasing to 9% of those aged over 80 years. It is associated with significant morbidity and a twofold increase in mortality. This is mainly because of its association with underlying heart disease, but also because of its association with systemic embolism and stroke. Now, the pathogenesis. Atrial fibrillation is a complex arrhythmia characterized by both abnormal automatic firing and the presence of multiple interacting re-entry circuits looping around the atria. Episodes of atrial fibrillation are initiated by rapid bursts of ectopic beats arising from conducting tissue in the pulmonary veins or from diseased atrial tissue. It becomes sustained because of reentrant conduction within the atria or sometimes because of continuous ectopic firing. Re-entry is more likely to occur in atria that are enlarged or in which conduction is slow, as is the case in many forms of heart disease. During episodes of atrial fibrillation, the atria beat rapidly but in an uncoordinated and ineffective manner. The ventricles are activated irregularly at a rate determined by conduction through the AV node. This produces the characteristic irregular pulse. The ECG shows normal but irregular QRS complexes. There are no P waves, but the baseline may show irregular fibrillation waves. Commonly, AF is classified as paroxysmal, that is, intermittent episodes that self-terminate within 7 days, persistent prolonged episodes that can be terminated by electrical or pharmacological cardioversion, or permanent. It can be difficult to identify what type of AF patients have at first presentation, but this usually becomes clearer as time progresses. Unfortunately, for many patients, paroxysmal AF becomes permanent as the underlying disease process progresses. This is partly because of electrophysiological changes that occur in the atria within a few hours of the onset of AF, and which tend to maintain fibrillation, a process called electrical remodeling. When AF persists for a period of months, structural remodeling also occurs, leading to atrial fibrosis and dilatation that predispose to chronicity of the atrial fibrillation. Early treatment of atrial fibrillation can sometimes prevent the arrhythmia from becoming persistent. Many forms of heart disease can present with atrial fibrillation, particularly those that are associated with enlargement or dilatation of the atria. Alcohol excess, hyperthyroidism, and chronic lung disease are also common causes of atrial fibrillation, although multiple predisposing factors may coexist, such as the combination of alcohol, hypertension, and coronary artery disease. About 50% of all patients with paroxysmal atrial fibrillation and 20% of patients with persistent or permanent atrial fibrillation have structurally normal hearts. This is known as lone atrial fibrillation. This figure shows a mechanism initiating atrial fibrillation. 1. Ectopic beats, often arising from the pulmonary veins, trigger atrial fibrillation. 2. Re-entry within the atria maintains atrial fibrillation with multiple interacting re-entry circuits operating simultaneously. This is the two examples of atrial fibrillation. The QRS complexes are irregular and there are no P waves. In diagram A, there is usually a first ventricular rate between 120 and 160 beats per minute at the onset of atrial fibrillation. In B, in chronic atrial fibrillation, the ventricular rate may be much slower due to the effects of medication and AV nodal fatigue. Now, the clinical features of atrial fibrillation. The typical presentation is with palpitation, breathlessness, and fatigue. In patients with poor ventricular function or valve disease, atrial fibrillation may precipitate or aggravate cardiac failure because of loss of atrial function and heart rate control. A fall in blood pressure may cause lightheadedness, and chest pain may occur with underlying coronary artery disease. In older patients, atrial fibrillation may not be associated with a rapid ventricular rate and may be asymptomatic, only to be discovered as a result of a routine examination or an ECG. Asymptomatic AF may also present with systemic embolism and is a major cause of stroke in the elderly. Now, the common causes of atrial fibrillation. The causes are coronary artery disease, including acute MI, valvular heart disease, especially rheumatic mitral valve disease, hypertension, sinoatrial disease, hyperthyroidism, alcohol, cardiomyopathy, congenital heart disease, chest infection, pulmonary embolism, pericardial disease, idiopathic lone atrial fibrillation. Now the investigation. Assessment of patients with newly diagnosed atrial fibrillation should include a full history, physical examination, a 12-lead ECG, echocardiogram, and thyroid function test to exclude thyrotoxicosis. This is an unusual but potentially treatable cause of atrial fibrillation. Additional investigations may be needed to determine the nature and extent of an underlying heart disease. In particular, echocardiographic assessment is useful to identify any structural heart disease, particularly mitral valve disease. Now the management. Management depends on whether the atrial fibrillation is transient or persistent and whether there is a clear precipitating factor. When atrial fibrillation complicates an acute illness such as a chest infection or pulmonary embolism, treatment of the underlying disorder will often restore sinus rhythm. Where atrial fibrillation does not resolve, the main objectives are to control heart rate during periods of atrial fibrillation, restore sinus rhythm, prevent recurrence of atrial fibrillation, and reduce the risk of thromboembolism. Management of paroxysmal and persistent atrial fibrillation is discussed below. Paroxysmal atrial fibrillation. Occasional attacks of atrial fibrillation that are well tolerated do not necessarily require treatment. Beta blockers are normally used as first-line therapy if symptoms are troublesome, since they reduce the ectopic firing that normally initiates the arrhythmia. They are particularly useful for treating patients with atrial fibrillation associated with coronary artery disease, hypertension, and cardiac failure. Class 1C drugs such as propafenone or flecainide are also effective at preventing episodes but should not be given to patients with coronary artery disease or left ventricular dysfunction. Flecainide is seldom used alone since it can precipitate atrial flutter and is usually prescribed with a rate-limiting beta blocker. Class 3 drugs can also be used. Amiodarone is the most effective agent for preventing atrial fibrillation, but side effects restrict its use to when other measures fail. Within the atria to prevent re-entry. Ablation prevents atrial fibrillation in approximately 75% of patients with prior drug-resistant episodes, although a repeat procedure is sometimes required before this is achieved. Ablation for atrial fibrillation is an attractive treatment when drugs are ineffective or poorly tolerated but may be complicated by cardiac tamponade, stroke, phrenic nerve injury, and rarely pulmonary vein stenosis. Persistent atrial fibrillation. There are two options for treating persistent atrial fibrillation. One is to attempt to restore and maintain sinus rhythm, and the second is to accept the presence of atrial fibrillation and to try to control the ventricular rate. With both options, prophylaxis against thromboembolism is required on either a short-term or long-term basis. Now, rhythm control. An attempt to restore sinus rhythm is particularly appropriate if the arrhythmia causes troublesome symptoms and if there is a modifiable or treatable underlying cause. Electrical DC cardioversion or pharmacological cardioversion may be used. Cardioversion is initially successful in most patients but relapse is frequent, 25 to 50% at 1 month and 70 to 90% at 1 year. Attempts to restore and maintain sinus rhythm are most successful if AF has been present for less than 3 months. The patient is young and there is no important structural heart disease. Immediate cardioversion is appropriate if atrial fibrillation has been present for less than 48 hours. In stable patients with no history of structural heart disease, intravenous flecainide 2 mg per kg over 30 minutes, maximum dose 150 mg, can be used for pharmacological cardioversion and will restore sinus rhythm in 75% of patients within 8 hours. In patients with structural or ischemic heart disease, intravenous amiodarone can be given through a central venous catheter. Cardioversion is an alternative treatment and is often effective when drugs fail. If atrial fibrillation has been present for 48 hours or longer, or if there is doubt about its duration, DC cardioversion should be deferred until the patient has been established on effective oral anticoagulation for a minimum of 4 weeks and any underlying problems such as hypertension or alcohol excess have been corrected. Consideration should be given to prophylactic treatment with amiodarone to reduce the risk of recurrence. Catheter ablation is sometimes used to restore and maintain sinus rhythm in resistant cases, but is a less effective treatment than for paroxysmal atrial fibrillation. Now the rate control. If sinus rhythm cannot be restored, treatment should be directed at maintaining an appropriate rate. Digoxin, beta blockers, and rate-limiting calcium antagonists such as verapamil or diltiazem reduce the ventricular rate by slowing AV conduction. This alone may produce a striking improvement in cardiac function, particularly in patients with mitral stenosis. Beta blockers and rate-limiting calcium antagonists are more effective than digoxin at controlling the heart rate during exercise and have additional benefits in patients with hypertension or structural heart disease. Combination therapy with digoxin and the beta blocker can help with rate control, but calcium channel antagonists should not be used with beta blockers because of the risk of bradycardia. In exceptional cases, poorly controlled and symptomatic AF can be treated by implanting a permanent pacemaker and then deliberately inducing complete AV nodal block with catheter ablation. This is known as the pace and ablate strategy. That is pace and ablate strategy. Now thromboprophylaxis. Loss of atrial contraction and left atrial dilatation causes stasis of blood in the left atrium and may lead to thrombus formation in the left atrial appendage. This predisposes patients to stroke and other forms of systemic embolism. And patients undergoing cardioversion to restore sinus rhythm require temporary anticoagulation to reduce the risk of systemic embolus. This can be achieved with warfarin, aiming for an international normalized ratio INR target of 2 to 3. Increasingly, direct-acting oral anticoagulant drugs are used as an alternative. Anticoagulation should be started for at least 4 weeks before cardioversion and should be maintained for at least 3 months following successful cardioversion. In patients with chronic atrial fibrillation, the annual risk of stroke is influenced by many factors, and a decision has to be made in which the risk of stroke is balanced against the risk of bleeding with anticoagulation. Patients with atrial fibrillation secondary to mitral valve disease should always be anticoagulated because the risk is so high. In other patients, clinical scoring systems can be used to assess the risk of stroke and bleeding. The risk of stroke is usually assessed by the Church-Vass score, whereas the Hasbled score can be used to estimate the bleeding risk. Patients with a Hazlitt score of 3 or more points may require more careful monitoring if anticoagulated. In patients with intermittent atrial fibrillation, stroke risk is similar to that in patients with persistent atrial fibrillation when adjusted for Church-Wass score. The risk of embolism is only weakly related to the frequency and duration of atrial fibrillation episodes. So, stroke prevention guidelines do not distinguish between those with paroxysmal, persistent, and permanent AF. Several agents can be used to reduce stroke risk in atrial fibrillation. Warfarin therapy adjusted to a target INR of 2 to 3 reduces the risk of stroke by about two-thirds at the cost of an annual risk of bleeding of 1 to 1.5% and is indicated for patients with a Church-Wass score of 2 or more, unless there are coexisting clinical risk factors that increase the risk of bleeding. These include peptic ulcer, uncontrolled hypertension, alcohol misuse, frequent falls, poor adherence, and the use of other drugs that might interact with warfarin. If bleeding does not occur in warfarin-treated patients, anticoagulation can be reversed. If bleeding does occur in warfarin-treated patients, anticoagulation can be reversed by administering vitamin K or clotting factors. The factor Xa inhibitors, rivaroxaban, apixaban, and adoxaban, and the direct thrombin inhibitor dabigatran collectively differed to as directly acting oral anticoagulants or DOACs can be used as an alternative. They are at least as effective as warfarin at preventing thrombotic stroke and are associated with a lower risk of intracranial hemorrhage. Other advantages include the lack of requirement for monitoring and the fact that they have fewer drug interactions. Agents that reverse the effects of DOACs have been developed. These include idarucizumab, which binds to dabigatran and allows acute bleeding complications to be managed more effectively. Aspirin should not be used since it has little or no effect on embolic stroke and is associated with significant bleeding risk. The table shows the Church-Wass score risk scoring system for non-valvular atrial fibrillation. C is congestive heart failure, score 1 point. H for hypertension history, 1 point. A2, age more than 75 years or equal to 75 years, 2 points. D for diabetes mellitus, 1 point. S2 means previous stroke or transient ischemic attack for 2 points. V vascular disease, 1 point. Age for age 65 to 74 years, 1 point. SC sex category female, 1 point. Maximum total score 9 points. Annual stroke risk 0.0%. No prophylaxis requires 1 point equal to 1.3%. Oral anticoagulant recommended in males only. 2 plus points. More than 2.2%. Oral anticoagulant recommended. This table shows Hazlitt bleeding risk scoring system for patients receiving oral anticoagulation. H for hypertension, current systolic blood pressure more than 160 mm mercury, then 1 point. A for abnormal liver function, cirrhosis or bilirubin, more than twice upper limit of reference range, or transaminases more than 3 times upper limit of reference range, abnormal renal function, creatinine more than 200 micromole per liter or 2.26 mg per deciliter, then each for 1 point. S stroke history 1 point. B bleeding history prior major event 1 point. Labile INR on warfarin 1 point. Elderly age more than 65 years or equal to 1 point. Drugs use of antiplatelet drugs 1 point. High alcohol consumption 1 point. Maximum total score 9 points. Hazlitt score of 3 or more than 3 points requires close patient monitoring. Now, atrial fibrillation in old age. Prevalence rises with age, reaching 9% in those over 80 years. Symptoms sometimes asymptomatic but often accompanied by diastolic heart failure. Hyperthyroidism. Atrial fibrillation may emerge as the dominant feature of otherwise silent or occult hyperthyroidism. Cardioversion followed by high rates 70% at 1 year of recurrent atrial fibrillation. Stroke. Atrial fibrillation is an important cause of cerebral embolism, found in 15% of all stroke patients and 2 to 8% of those with transient ischemic attacks. Anticoagulation. Although the risk of thromboembolism rises, the hazards of anticoagulation also become greater with age because of increased comorbidity, particularly cognitive impairment and falls. Target INR. If anticoagulation is recommended in those over 75 years, care should be taken to maintain an INR below 3 because of the increased risk of intracranial hemorrhage. Directly acting oral anticoagulants. Alternatives to warfarin. No blood monitoring is required. There are fewer drug interactions and fixed dosing may aid adherence. Dabigatran dose is reduced from 150 mg twice daily to 110 mg twice daily in those over 80 or if creatine clearance is less than 30 ml per minute. Rivaroxaban dose is reduced from 12 mg once daily to 15 mg once daily if creatine clearance is 30 to 49 ml per minute and is contraindicated below 30 ml per minute. Thank you friends.